giving a talk on handling obstetric emergencies at Taluk level in private practice.
Dr. Girish, MK, he is MBBS DA and consultant anesthesiologist. Education, MBBS from Kim Subli in 2007, DA from MMC RI Mysore 2011. Experience 2011 to 2015, freelancing at Kadur and Arsikre. 2015 to 2016, specialist CHC Bureau. 2016 till now, consultant SS Hospital Tiptor, freelancing in Tiptor. Leadership, President IMA Kadur and Bureau. Interest, peripheral nerve blocks, labor anesthesia. To you, sir.
Thank you, sir, for the brief introduction. Good morning, everyone. Myself practicing anesthesiology ever since I completed my diploma anesthesiology in peripheral places only, in Taluk places. I went back to Taluk place just because my uncle had a small nursing home over there. So he was very busy. Both husband and wife are surgeons, surgeon and gynecologists. They were very busy and finding difficult to find the anesthetist in time. So that is how I went into peripheral place. So coming to the topic, obstetric emergency. What is obstetric emergency? It is a life-threatening condition either to the mother or the fetus during pregnancy, during labor or even after delivery. So 90% of the emergency calls what we receive in peripheries are mainly from obstetricians. In those 90% are major hemorrhagic complications. Other complications like preeclampsia, eclampsia and related complications, fetal distress. This is the term commonly used. Anything meconium strain, fetal distress, bradycardia in the NST, fetal distress. So an obstetrician will be in distress and call all the time. Then others like cardiac and pulmonary complication. Patient is shifted to ward from the OT. We don't find any ICUs in the peripheries. They directly shift the patient from OT to ward. The ward will be like a small, large rooms will be there, no? Like that, we cannot assess the patient from any side except one side. So it will be very restricted, small bed. So we cannot do anything in the ward. Whenever a surgeon or obstetrician calls me in emergency in the ward, I first tell them to shift the patient to OT. Don't do anything there, just shift the patient to OT. That is what I tell. Then to introduce this, I think Madam and Sir have already explained in detail. Primitive setups. When I went, primitive setup means in all things, equipments, only Boyle's basic machine with a big cylinder attached to it in the OT only will be kept in the OT. Drugs, you never know which drugs are available, which are expired. Emergency drugs will not be available in the OT. You have to check before starting the case, any emergency case for that matter. Don't assume anything. So airway gadgets, you have to keep your airway gadgets with yourself. Nobody will provide LMS, bougies, even bougies they won't provide. Stillet will be there, and that too after searching for 2-3 minutes they will give if you ask. So skilled staff, this is a big question. Any staff who is very much skilled, who can handle complication, identify you the complication and help you, they will not stay back in the peripheries. They will just migrate to higher, bigger places like Mysore, Bangalore, or district places, I think. Then blood bank. I don't think any Taluk in Karnataka, any Taluk place is having its own blood bank. Maybe because it is very difficult to maintain the blood bank, very expensive, and requirement of blood in peripheral places is very minimal. So maintaining the blood bank is a very big task. So it is very difficult to find them. And lack of teamwork. You are the only anesthetist in the town for 4 or 5 days continuously, or some anesthetist is available but he is in leisure or engaged in some other case, so he cannot come in time. Or lack of team is not only anesthetist, any doctor for that matter. Another surgeon, whenever the surgery is getting complicated, a patient is bleeding on table, PPH, she may need some help from the other obstetricians. It is very difficult to find the other obstetricians. They will panic and we have to take the burden also to arrange other doctors. So there will be no ICU backup. equipments, these things already discussed in detail. I don't go in detail about those things. Endotracheal tubes, I have seen on nursing home, they have kept red rubber ET tubes. Have you anybody seen red rubber tubes?
I used.
Yeah.
Used 10.5.
Yeah, those are very old ones. Those tubes are still kept in this hospital in a small cover, zipped cover. All the old equipments, endotracheal tubes, airways.
And it was good and is reusable.
Now also they have kept those tubes only. So I have not used those tubes in my post graduation. I was surprised to see them. What are those things? So that is the condition. They never update themselves. We will have to pressurize them. Airways, face masks, they will be damaged. Proper fitting mask will be not available. Then oral suction catheters, they will not would have been not washed when used. They will be dried, dirty. So these are the conditions in peripheral places because they are not used to it. Once in a while, once in a year or 2 years, they may be using them. So laryngoscope will be there, batteries will not be there, or blade will be there, bulb will be absent, or it is bulb, blade, battery, everything will be there. When I put the scope into the mouth, the light will be flickering and off. So supraglottic airway devices will not be available. I have kept my own set of airways. So drugs, many nursing homes, they will not keep general anesthesia drugs. What they think is, we are not using general anesthesia drugs regularly. They will be expired. It is a liability for us. Why should we keep GA drugs? Whenever I ask some drug, ketamine, that is a very big problem. In emergency, hemorrhagic cases, we have to use ketamine. They used to take a prescription slip, write it and give to patient attenders, go to so and so pharmacy and bring it. This is the condition in peripheries. Staff that I already explained many times, they trouble us rather than helping. Just 4 days back, I asked a staff nurse to load an ampoule of atropine before giving spinal anesthesia. See, she loaded adrenaline. She loaded adrenaline. I have made it a point that any drug loaded, it should be labeled. Preferably that ampoule should be there with the syringe. That is what I have made. So that's why I identified it. Then skilled staff will not stay back in small towns. Then blood bank, I have already explained in this. Nearest blood bank to my place is 50 kilometers away. So handling hemorrhagic complications is a nightmare for us. Many patients are sent to IS center just because of anticipated hemorrhage. Multipara with low HB coming in labor, or HB of 9 with negative group. So we cannot arrange blood immediately. So we keep on referring these patients. Blood transfusion done by local collection with blood banks just to save the patient's life in emergencies have been done, and later some of the doctors have landed in problems. So lack of teamwork, difficult to get a team to handle complications. Sometimes you are the only anesthetist in the town, and finding another surgeon in times of surgical complication is also a very difficult one. That junior doctors not experienced to handle the cases, so they will become panic, and we have to take the responsibility to arrange surgeons. I have done some surgeon to come from faraway place, 40-50 kilometers away place to this OT to handle the case. That is what I have done. So staff in the OT they will not be knowing anything. They will be just observing what we are doing. So keep a kit of all the emergency drugs and gadgets and keep it in the car and keep replacing after expiry. That is what I am doing. So how to avoid mishaps? In emergencies, everybody is trying to do something and they will commit mistakes. So whatever may be the situation, just go with basic things like thorough cockpit drill. It will not take much time. Just 30 seconds to 1 minute is enough to check everything. So never miss that. So never assume things like just 2 hours back I have given spinal anesthesia to LSCS. Everything I have checked. So after 2 hours I am going there. No, so everything will be there. No, never assume. OT is like a storeroom for small nursing homes. For everything they will go to OT, take away cannulas, syringes, emergency drugs, everything they will take away. So never assume just because you have done a case 1 or 2 hours earlier, it is not like that. So always make sure that there is enough oxygen and oxygen cylinder opener is in place. Cylinder will be there, it will be full, but opener will be missing. So we have to make it show. Never trust anyone unless you are monitoring them directly. So don't, sister is telling that, sir, this is bupivacaine loaded, sir. Don't ask her to show the ampule. So never use pre-loaded drugs. Sir, this is a methamphetamine, sir. So and so doctor loaded 1 hour back, sir. So use this. No, never use unless it is labeled properly. So I will just go through some case scenarios which I have handled in periphery. A 22-year-old primigravida, 39 weeks of gestation, posted for elective LSCS. Examination finding and pre-op investigations were within normal limit. I gave subarachnoid block 1.58 ml at L3, L4. Patient turned supine and started painting. Suddenly monitor stopped showing any reading. I just felt the pulse, it was palpable and good value, but monitor was not working. It was very poor quality monitor. So I just neglected that, and after that again I felt the pulse was not palpable. Patient didn't respond to my verbal commands and I couldn't feel the pulse. So everyone in the OT were panic. What obstetrician did is she started eating the patient, nothing else. So I just auscultated the chest of the patient. I could hear the cardiac sounds. So I thought it is supine hypertension maybe. So I asked the obstetrician to extract the baby as early as possible. So I put a wedge myself. Nobody was there to understand what is wedge. So I put a wedge and tilted the table and tried to push the uterus to the left side. Then asked someone to push IV fluids. So this thing is, everybody put a needle on the fluid bottle. Multiple punctures they will do. If you ask the person to push the fluid, they will be pressing the bottle. That fluid will be coming out. It will not be going. So you have to change the bottle. Ask them specifically not to prick the bottle. Just change the bottle, push it. So I gave a bolus dose of methamphetamine and tried to intubate but failed. She was holding her mouth very tight, not able to intubate. So I started ventilating with the 100% oxygen with vein circuit. So after extraction of the baby, monitor showed some readings to ease my breath. I sweated so much that that is the day I realized that it is very difficult to handle emergencies in peripheries. That was about 15-20 days after my post-graduation. So few minutes, sir, 2-3 minutes. So then one more is ruptured ectopic gestation. This case I will never forget. I got a call from the hospital. Just by the voice I could realize that it is really an emergency. When I entered the street of the hospital, hundreds of people gathered outside the hospital. Obstetrician immediately entering the OT, obstetrician told me that patient is UPT positive, collapsed in the morning at her home. She had come from Bangalore to attend her brother-in-law's marriage. So she diagnosed it as ruptured ectopic. When I went inside, the patient herself is a gynecologist, wife of my close friend and daughter-in-law of the local MLA. Just imagine the pressure. Daughter-in-law actually. Patient was in hemorrhagic shock. Blood was not available. Then blood investigation reports were awaited. Don't know what is the HB. She was papery white, gasping almost. Everybody is trying to arrange the blood. And I immediately explained that situation to my friend. He agreed. Anyway, he is a surgeon. No, he can understand. He agreed. Only Boyle's basic apparatus was there. So I immediately established an IV cannula 18 gauge, one in external jugular vein. Then under GA I did. After 30 minutes, everything procedure was over. So patient saved. Post-op, intra-op 2 units of blood transfused, locally collected without any proper precautions. Then extubated after 1 hour, shifted to so-called ICU. Then 2 more units transfused in the post-op. I gave my 1 unit of blood. So another case is placenta previa. This was placenta percrita. Sorry. This case, after giving spinal, it was an elective case. Took at 9 p.m. in the night. After opening the abdomen, surgeon was telling, sir, everywhere I can find blood vessels. There is no place to put the incision in the lower segment. I will put it in the upper segment, he told. Just I went that side and saw the area. I could see only blood vessels, nothing else. So I realized something is wrong. There may be some placental abnormality. I didn't see any cases till then. So I told him, sir, please don't proceed, sir. Please stop. So then I went and checked the USC report. In there it is mentioned that placenta is anterior. So I thought it is placenta only. That is the only diagnosis I could make. So the hospital owner was an MBBS doctor practicing since 30-35 years. He only used to do sonography. He only used to do MTPs like that. He was practicing. Then he told that, sir, there are no attenders with the patient, very poor patient, only one old lady is there, nobody is there to take her to higher center. Please go ahead, I can arrange 2 units of blood immediately. If anything happens, I can handle. That is what he told. So he was forcing us like anything, because already abdomen open, closing back the cesarean patient is very difficult. But I was very adamant. Surgeon was somewhat convinced that he was confident that if there is a bleeding, I can immediately put two clamps here and remove the uterus. That is what he was confident about. So I told them to not proceed. Luckily, patient hemodynamically she was stable. So ambulance arrived after 2 hours. So then all 3 of us went with the patient in the night, because there were no proper attenders to go with her. So keeping everything ready we informed before only to the on-duty doctor. So she arranged the blood and took the case and did hysterectomy, and patient saved. Undiagnosed placenta previa. This was also a case of elective case. After putting incision, there was profuse bleeding. Surgeon also was not knowing what it was. With difficulty extracted, any amount of drug didn't do anything, so patient became hemodynamically unstable. No one to help me. 1 unit of blood transfused with difficulty, we arranged, converted to GA. That is the day, this I remember. So this is for surgeon actually. Why did I get involved in this operation? That I felt. Why did I become an anesthetist? Why did I study to become a doctor? All these feelings I had that day. Why did I born? Literally I felt this. Literally, because she was bleeding profusely, no consent was taken, nobody was there to explain, but she was bleeding. So hysterectomy was done and patient became stable, and patient had regular ANCs in PHC where they diagnosed it as low-lying placenta. Patient attender kept that report with her. They came in labor. So surgeon proceeded. Since then I started looking even ultrasound reports also. Tonic PPH, it was in the night after normal delivery, patient bled. We called for help. I called my one more colleague to handle the situation. Then inotop started, EJV cannulation done. There was no blood available. Patient arrested on table, shifted in the ambulance to 70 km away hospital. And while shifting also, she arrested in midway, again resuscitated, then shifted to higher center where they did opened the abdomen and all surgical manuals and drugs. With that she stopped bleeding. Then after 2 years, she came back with another pregnancy. Nobody in the town was ready to even give ANCs to that patient. So that day, it was World Anesthesia Day. Everybody in the town was appreciating us. All doctors called us, both anesthetists, and everybody was wishing us. That was the only year, that was the first year, everybody was wishing the anesthesia day. So pulmonary edema, this was after doing a cesarean section, shifted to ward. 1.5 hours later, patient developed breathlessness. Within minutes, she developed pulmonary edema and collapsed. No monitor was attached to her in the post-op ward. Just sister was going and checking the BP. So patient developed hypoxia. My colleague went there to resuscitate, but in patient had cardiac arrest and not able to revive. So one more case is case of jaundice. Elective cesarean section taken at night 10:30 p.m. It was actually semi-emergency, like patient is in labor, previous cesarean section. So when I went in, everything was ready. Patient was put on left lateral position, back was painted, and surgeon was holding the spinal needle. I just went in and saw the patient. I was in some doubt. Profuse edema was there. BP was around 150, 80 like that. So I asked the patient, talked to her. Everything was normal. So I thought everything is normal. Let's go ahead. Suddenly I saw the urine bag. It was greenish color. In the night also I could recognize it was greenish color. I just asked the surgeon whether LFT has been done. No, not. It has not been done. So I asked for LFT, lab was not there, lab technician was not there, and LFT, getting LFT was a big thing for us in those days. So I refused the case. Obstetrician was very angry on me. So I have convinced them since last 2 hours they are in the hospital. So I have prepared everything on table. How can we shift the patient to higher center at this time? That was the words she used. But I was very adamant. I made her to shift the patient. Later we could realize that the patient went to some corporate hospital. There they refused. Went into medical college. There they referred to some other college. Went into Manipal hospital. There they did the cesarean section. Baby died. Patient was in gastroenterology unit for almost 1 month, and she succumbed to hepatitis. That day, obstetrician was very happy. This is what we get back in peripheral places. So non-technical skills are also very important while practicing in peripheries and handling emergencies. A good vigilance, keep observing everything. You should observe all things. Then anticipation of complications. So clear communication with the doctors and staff in the OT and also with the patient attenders is very important. Team coordination. You will be the leader in crisis. You have to take leadership and coordinate to do things. Decision making, whether to proceed, not, what to do, what not to do. These things you have to give advice to the surgeons. And leadership quality is very important, and managing stress and fatigue in the peripheries is a very difficult thing, but we have to cope with that and practice safely. So I always stick to basics. PA is a must. Don't hesitate to refer the patient. Well-informed consent. So these days we are practicing taking consent with video records, so that patient attenders will know that we are keeping records. So non-technical skills in handling situations are very important. Thank you.
Thank you, sir.
Thank the organizers for giving this wonderful opportunity. Thank you, Ananda.